Recording.
She looks like she's so excited to
She
talk to
is.
us. That's
Very
awesome.
There we go, and it's being recorded, it says.
Right.
Well, hello, everybody.
Hello.
Thank you very much. Thanks for inviting me. This is really a great opportunity for me. It's really exciting. I really like the questions that you sent. They're very on point. So hopefully, I'm going to try to answer them as best as I can. Of course, we all know this is a sort of changing project out there, sort of, the healthcare mandates and things like that. So tomorrow it could be different, but for right now, I'll try to do my best. And I want to start actually I'm going to ask you a couple questions first, and feel free to, ask me questions either as I go through or maybe at the end. Let me start by, you may have seen, whoops. All right, I was going to start by asking you, but obviously you've already seen the answer to this one. So just by way of sort of showing us how we got to this point, why we were ever looking for the Affordable Care Act or the now American Health Care Act, some of the things that we were looking at, we look at, first of all, health outcomes. And we can look at infant mortality, we can look at disease rates. One of the things that we look at is life expectancy at birth. And you can see for the United States, it's been around 78.8, 78.9. So we're roughly around 79 years is our life expectancy at birth. So that's the average. And when we take a look at other countries are similar, but these are just a few. I took a few examples from some of the OECD countries. So you can see, for example, some of the countries actually have longer life expectancies. You see the US way down there at the right, 79, and you can see that some of the countries have life expectancies at birth that are over 80 years. So I want you to keep that in mind as we take a look at some of the other statistics for these countries. So we're really not the best. I mean, if anything, we're comparable to some of these other countries. So the other thing is, let me just ask you guys, do you know what the uninsured rate is? Any idea? How many people in the United States under 65, because remember, over 65, they're going to be on Medicare, but under 65, what percent of the population is uninsured?
Is it close to 78%?
Is it less than what?
Is it like close to 78%?
7 or 8?
No, 78.
Oh, 78. Oh, no, uninsured. So
Uninsured. Okay.
uninsured. So insured 78. If you said insured was 78, you would expect uninsured would be about 20. And it was that, close to that anyway, 17% before the Affordable Care Act. So this is actually one of the things that we were concerned about, was the number of people that were uninsured. And everybody pretty much agrees that the Affordable Care Act has helped that. I mean, we can see that since, it was put into place and then, actually gradually was implemented. Now in 2016, we're down below 11% uninsured. We'd really rather have it close to zero. So there are some problems with having a lot of people who are uninsured. One of the problems is they tend to, when they do get sick, if they don't have insurance, they tend to wait. They're not going to use preventive care, so they wait until something's catastrophic, which means it's more expensive when they get treatment. It's also a sort of a trend with people who are uninsured. Because they wait until their illness is catastrophic, they may end up in the emergency room. And there might be a more cost-effective setting if they could treat the disease a little bit earlier. So this uninsured situation ends up being very expensive, and we don't like to see that many people uninsured. So the last thing I'm going to ask you to guess, how much do you think we spend per person? So this is per capita. So in the entire United States, on average, so, there are going to be some people who spend a whole lot, some people who spend nothing. What do you think the average is per person? Any idea?
Around 300.
300? Any? Anybody agree, disagree, think it's more, think it's less?
We're saying more. Here's another answer. I think it's more.
You think more than 300?
Maybe 10,000, whatever.
10,000? Okay, that's a big range, 300 to 10,000. But yeah, 2015 it was close. It's supposed to, in 2016, it's expected to hit 10,000. So we spend per person in 2015 over $9,000 on average. Now, remember back to what I told you at the very beginning when we looked at life expectancy. Remember, we were comparable with other countries in terms of life expectancy, and some of the other statistics that we look at to measure health are also, we're comparable. But look at other countries' health expenditures. So Japan, who I should have pointed it out on the first slide, but Japan had the longest lifespan. They spend half as much on healthcare. So the question is, what are we doing? Why are we spending so much on healthcare? It doesn't look like our outcomes are that much better. Now, to be fair, when we drill down and look at particular diseases, there are some diseases that we treat better than others. But overall, if we don't have better infant mortality, longer lifespans, why are we spending twice as much on healthcare? So that was another reason why for years we've been looking at having, okay, what are we doing wrong? Why are we spending so much? We could, in theory, spend less and still have the same outcomes. So I'll come back to that also at the very end. When we get done, we'll chat about that a bit. But that's one of the big concerns, is that healthcare is so expensive. We're spending so much of it. A huge part of our gross domestic product ends up being spent actually on healthcare. And again, without any real noticeable, it's not like we have twice as good of outcomes as some of these other countries. So put all this in framework. So this is our big problem. We have some people who are uninsured. We spend a lot on healthcare. When we take a look at how health works in our economy, we have a capitalist economy. We have a consumer. I know there's stuff all over this slide, but we have a consumer, and actually there are econ models that actually treat the consumer, the person who's buying healthcare, actually as if they're producing health. And healthcare is one of the resources used. So just like you make a car, one of the resources is steel. They treat consumers as a producer of health. One of the resources is healthcare. Other resources include exercise, nutrition, all of these things just so that we can produce good health. So we're purchasing healthcare and using it as a resource. And we're purchasing it from a healthcare provider. You see I've listed the healthcare provider on the right. So these are doctors, hospitals, pharmaceutical companies. But this is different than other markets in our economy because we don't know what the price is. And I know you all are students of economics, and I think you've been taking it for a few weeks now. So you know that what we rely on in a capitalist economy is that when something becomes really desired, people are willing to pay more for it. And that tends to serve as a signal to producers that more needs to be produced. And that's how the economy sort of adjusts without any manual intervention. But in healthcare, the consumers don't know what the price is, which causes a whole lot of issues and can actually contribute to higher cost of healthcare. So consumers not knowing how much the price is, they may not be able to choose the less expensive option because they don't know what that option is. So that makes it really complicated. And on top of that, we have intermediaries. We have businesses other than healthcare providers, just whoever you work for may offer you healthcare as an employee benefit. So it's a form of compensation. So those businesses come in and negotiate contracts with providers. We have insurance companies who act as the agent. They assume risk in return for a fee. And the classic model of an insurance company is that what they're really doing is pooling risk. So in other words, in the most simple example would be like if you buy homeowners insurance. So maybe you're buying homeowners insurance in case something happens like your house catches on fire. There's a very small probability that's going to happen. And maybe in your entire neighborhood, there may be, 10,000 people maybe, and maybe one of those houses will burn down. The problem is, if it's your house, it can wipe you out. But if everybody pitches in a little bit of money, and then whoever's house burns down is the one that's covered, that's the theory of insurance. So you take the risk and you pool it. You get a little bit of money from everybody in order to pay for something catastrophic. So that's, the insurance company serves that purpose in healthcare. But there's also another component to that, because some of our healthcare isn't unexpected or catastrophic. Some of our healthcare we know we're going to be needing. Dental services, for example, we know we're going to use. Maternity benefits, if we're planning a family, we know we're going to use them. So it's not a risk it's going to happen, it's something we know is going to happen. So in those cases, the insurance company actually is acting as a place where you can sort of pre-save. So you pay into this policy with the idea that down the road you are going to need healthcare, and at that time you use the money that you've been prepaying. So it's kind of a complicated system because it's not purely insurance, really. And then, of course, government, I put question marks on everything because we have no idea what government's role should be. That's why we're playing around. That's why we tried first the Affordable Care Act, and now we're looking at modifying it or maybe even repealing it. So, you know, what role does government play? Should they just be regulating the healthcare providers? Should they be actually stepping in themselves and acting as an insurer? Should they be managing the risk? Should they be acting as the plan administrator? Should they be using healthcare as a way to redistribute income and maybe make it a little bit more affordable for people who have low income? So it's really complicated. And, you know, I tried to sort of capture that here, but you see there's a lot of people involved. So because of all these roles and because of these complications, and again, because of the high cost of healthcare in this country, that's why we ended up taking a look at, okay, what can we do? Should government be playing a little bit different role? And that's how we came, you know, to actually eventually have the Affordable Care Act. And the Affordable Care Act, just this quick review, I don't know, if you guys are familiar, are you guys kind of familiar with it?
Yes.
Or not really? A little bit? So, you know, these are the main things that the Affordable Care Act tried to, or, you know, has done. Insurance for all, which, you know, it's almost all now because uninsured is down to 10%. Offered a preventive care for everybody. A lot of people didn't have preventive care before. Required a minimum benefit package. Some people had just catastrophic coverage or coverage for certain diseases. Expanded Medicaid, and this is a huge one because prior to the Affordable Care Act, Medicaid was different from state to state. Some states you could qualify, you know, if your income was below the federal poverty level. Other states you could qualify if your income was a little bit higher. And so the Affordable Care Act standardized all that. And most people qualify as long as they're below 138% of the federal poverty level now, which is an expansion from what it had been. Of course, Affordable Care Act mandated coverage, everybody has to have it, and precluded pre-existing conditions, so an insurer can't refuse you for pre-existing conditions. Of course, also established those healthcare exchanges, gave tax breaks to people who had low income and had trouble affording coverage, allowed children to stay in their parents' contracts until they were 26, and some other things too, but these are the things that we hear about the most. So this is our baseline. This is where we start. Now we have a proposal, of course, to repeal the Affordable Care Act. And in its place, the proposal is now this American Health Care Act. And so some parts of this may end up staying, some parts of the Affordable Care Act may end up staying. So these are the things that the American Health Care Act is planning to change. The things that they want to completely repeal are the mandate for insurance coverage and subsidies, although they are replacing the subsidies that did exist with new subsidies, and I'll show you how that works in a couple of seconds actually. They also, the things that they're keeping are the coverage for people with pre-existing conditions, the coverage for children, and they're allowing that Medicaid expansion to continue until 2020. And then, or at least that's the proposal. And then after 2020, they're expecting to, anybody newly enrolling in insurance will no longer be doing so under that Medicaid expansion. It would be up to states at that point to decide again, and it may differ from state to state, you know, how you would be eligible. So, and they wouldn't be federally reimbursed for it like they are right now. They're getting some subsidies for that. So the big problem with this is from an economic standpoint, when you study health economics, of course, it's all about incentives. You take always econ is about incentives. The problem is that if you require coverage for people with pre-existing conditions, you kind of have to have a mandate of some sort or something, because otherwise if I know that you can't turn me down for pre-existing condition, why would I buy insurance now? I could just buy it when I get sick. You can't exclude me. If I get sick, you can't exclude me. I'll wait till I'm sick and then I'll buy it. So that's the reason when you refuse to allow pre-existing conditions, that's the reason you have to have something so that the insurance companies don't go broke on it. If all they did was collect, a couple $100 premium from somebody and then pay out a couple $1,000s of claims every time, it wouldn't be fiscally sound. Now, what the American Health Care Act is suggesting is instead of the individual mandate and the employer mandate, they are allowing, through the very last bullet here, higher premiums for people whose coverage lapses. So in other words, let's say you're on your parents' insurance until you're 26. At 26, you don't pick up any insurance on your own. Now you say you turn 28 and now you have a good job, you want to buy insurance. Insurance companies would be allowed to charge you 30% more for the first year. And this is the American Health Care Act's disincentive for people to let their policy lapse. So instead of requiring that you have insurance, which right now the Affordable Care Act requires it, or else you're penalized on your taxes, instead they have this 30% surcharge for people who allow their policy to last. So that is the deterrent for waiting until you get sick to get a policy. So I should ask you, what do you think? Would that work?
No.
Think that's enough of a deterrent?
No.
All right. No, because
With the higher premium on the lapse of coverage.
right, it's a higher premium if you don't buy insurance, if you don't stay insured. When you do go to buy insurance, they can charge you a 30% premium on top of your regular insurance for the first year.
So that's just like car insurance. If I know I've been in like a bunch of accidents and I can't get covered, I'm going to take my chance and drive around until I get caught. And that's just like with healthcare. You're going to just walk around until you're healthy, until you get sick, and then it won't matter because you're going to get either treated or you're going to die. And that's really what I think is going to happen if they pass this reform. Because I'm experiencing this right now with the Affordable Care Act now. I was in between jobs. I waited 30 days and I signed up at the marketplace. So now, because I got tax credits for 7 months, they're going to get me on the back end with my taxes. I would rather that to happen as opposed to pay a higher premium, because at the time I was not able to afford premium at that time, and the tax credits and the subsidies help. So now that I'm back at a full-time job and I have coverage through my employer, I'll take that loss as far as my refund. And then what they don't tell you is if your refund, if your repayable amount in the tax credits, if you receive them, if they are more than what you're going to receive in your refund, there's other subsidies that you qualify for, so they won't just completely take all of your tax. Am I correct with that?
Okay. It depends. It depends. I mean, it depends on your income. But in the end, if you end up, first they calculate how much of a credit you should be getting. In the end, if their calculation is wrong or, for whatever reason, you end up taking more of a credit than that, on the back end, you usually have to make that up.
Okay. But I don't think the higher premium for those who will have a lapse in coverage. I don't think that's going to work.
Okay.
I think
So,
this should be revisited on both sides as far as the tax credits, the subsidies. They work, but some people have issues with paying it on the back end of income tax and
right.
or paying the
Mhm.
penalty as well. But I'd rather pay the $92 or whatever the amount is. I think it's 92 for the penalty as opposed
Right.
to paying higher premium.
And the penalties, if you're getting a tax refund, they take it out of your tax refund,
Correct.
which is different than having to come up with 30% more up front. You're right. If you don't have it at the time, you don't have it.
Right.
Yeah.
And that, I think with the higher premiums, they're giving the insurance companies too much leeway to inflate inflate premiums
Uh-huh.
if they're not regulated. I think with the Affordable Care Act now, what we watched in the video we saw,
Yeah. Oh,
you have an opportunity to make sure that insurance companies are monitored and
uh-huh.
regulated as it relates to how much they charge.
Right.
So under this new plan, there's no type of regulation for the insurance companies?
They still have to get approval for a rate increase over 10%, I think. That part they kept, yeah.
Thank you.
Right. And that's how it is with the Affordable Care Act too. They have to justify any increase over 10%. So in some cases it has been approved and it has been justified. And there's also that 80-20 rule, which is that they have to pay 80% of what they take in has to go toward claims. Can't go toward administrative costs. And as far as I know, that's still there. So there have been insurance companies that have messed that up, and they had to give refunds to people. So they do have that. They're also, though, talking about restructuring Medicaid so that states receive money from the federal government. So then this all would fall on states to regulate. And, depending how that plays out, we could end up with differences from state to state again, which, was a problem that we had before the Affordable Care Act, was that there were discrepancies from state to state. So we could end up having that again, which, then you have problems with the pooling. It's not as big of a risk pool.
So when you say discrepancies in terms of Medicaid from state to state, do you mean
Right.
Some states cover things whereas other states won't cover things?
Correct.
So as a part of this, I know.
And also the eligibility requirements can be different. So, Medicaid is means tested, so it depends on how much income you have. But in the past, some states you'd have to be below federal poverty level. Other states would say you have to be below 120% of federal poverty level. So the Affordable Care Act standardized that. So your income level has to be 100. States actually can make it more generous, but it has to be at least accepting people who have incomes below 138% of the federal poverty level.
And I know this may sound like a strange question, but in talking about this, there have also been talks about crossing state lines. Would crossing state lines in terms of purchasing insurance or being eligible for insurance, would that also work with Medicaid? So let's say I live here in Louisiana and the condition I have is not covered under Louisiana's policy or law, but it's covered under Mississippi, and I'm a Medicaid recipient. Would I be able to then go into Mississippi where my condition is covered?
Well, the crossing state lines controversy is about the insurance companies. Okay. So it's not Medicaid. It's the insurance companies would be able to sell policies in other states.
Okay. So if Medicaid is specific to the state you live in?
Yes.
Okay.
That's why the Medicaid expansion just happened for Louisiana in 2015.
So what is the Medicaid expansion? I really don't understand
the Medicaid expansion changed the eligibility. Well, what it did is it required states to meet a minimum standard that they have to accept on Medicaid everybody whose income falls at 138% of the federal poverty level or lower. Before that, some states had income caps that were lower than that. So there were some states where, let's say your income is at 130% of the federal poverty level. In some states, you would not be eligible for Medicaid. Other states, you would be eligible for Medicaid. Okay. So the Affordable Care Act made it 138% across the board. And then the federal government reimburses states so that they're able to, afford to do that.
Okay. So would there still be, and I think you may have mentioned this, with the new plan, the American Health Care Act, would there still be reimbursement for the states with Medicaid?
They're talking about if you're talking about, if you're including the restructure of the Medicaid program, then no, they'd be turning over blocks of money to the state. So each state would get a block of money based on how many people are enrolled in their state, and they would be able to have different requirements then again, because it would be up to them to administer those plans.
Okay. That'll run the risk of individuals not being completely covered. Dr. Kramer, could you also talk about what they're going to do with the CHIP? Well, the children's coverage, children's health coverage.
Now, states in the past have actually been pretty good about children's health coverage. So, like, a lot of the states have had, for adults, they had federal poverty level caps that were, low. But for children, they have them pretty high. Most states are actually higher than what's required. So some states even have, if you have income that's up to, some of them have even up to 300% of federal poverty level, children are covered.
Okay, because I read somewhere where the American Care Act was going to kind of revise as far as on the state level, how they provide medical care for children who are already on Medicaid or will apply for Medicaid under, like what we call here in Louisiana, the CHIP.
Well, will that, Dr. Kramer, will that have anything to do with the age? With the CHIP, will they cut it off age-wise? Like if a child turns, like let's say 19, they're at that point taken off of the CHIP and they will go into Medicaid, or do they have to go under their parents' health insurance at that point?
If their parents are qualifying for health insurance, but yeah, if their parents qualify for health insurance, they go on their parents. If they don't, then they stay on Medicaid. But again, what they're trying to do with the American Health Care Act is turn all those decisions over to the state. So they would give the states a block of money and let them decide how to administer it. So instead of it being federal program, it would be state programs.
They want to get out of government aid.
Right. They want smaller government.
Right.
They want smaller federal government,
right.
Turn it over to the states.
Right.
But in all actuality, it's going to still increase cost, and it's going to increase, our deficit. It's not going to reduce our deficit. Am I correct?
Actually, no. That's the claim to fame, is that it's supposed to save money. That's their whole, selling point, is that it will save money. It would end up saving money for the federal government compared to what we pay right now. But because there'll be so many people who aren't insured.
Right, but you're going to be back to an enormous amount of people going to the emergency room for preventative care.
Right.
Well, it could have been prevented if they
right.
had reasonable health care to where they can go to a PCP and get follow-up care. It's going to go back to that. And I don't know if this situation will be, and it's just from personal experience with having quote-unquote Obamacare. I don't know if this is going to be reliable as it relates to what we already have now. I don't see where this is going to make a big difference, but I don't know, I don't know.
And the whole point is to have smaller federal government and to have lower healthcare spending. So, I mean, they're talking about going back to the way it was before the Medicaid expansion. So you're talking about going back to a lot more people uninsured.
Yeah.
So yeah, you can save money if you're insuring fewer people.
And your emergency rooms will be overwhelmed again for very, very simple illnesses.
That could be, yes.
As opposed to what's going on now. More people are participating in, regular care, follow-up care.
Preventive care, yes.
Preventive care, more than ever before, because it's affordable.
Yes.
So if you go back to what we had before, you're gonna have, it's just gonna be a repeat. I mean, we gotta take politics out of this and just really realize what's best for your constituents and for, the states as a whole, the country as a whole.
Yes, but it depends who your constituents are too, because let's take a look. I know some of you sent questions about, how the two compare, and this is a great website. You guys should play around with this after I'm done. This is the Kaiser Family Foundation, and I do have this slide at the end with links to the sites, and actually I will send that. I'll send a copy of these PowerPoints as well. But what you do is you go on that website and you can put in your age and how much you make, and it'll tell you the difference between the Affordable Care Act and the American Health Care Act. So I just played around with it here, and I did it for different income levels, different ages. And the blue stuff is the people who are going to get a smaller tax break. The orange, the darker orange, is people who are going to get a larger tax break. So if you take a look at the people making $100,000 at the very bottom line. Those people are all going to get larger tax breaks than they did under the Affordable Care Act.
Of course, it's geared for the rich.
Yeah.
Right. And if you look, I mean, the one that's got almost no orange at all is the 60-year-old person making $20,000 a year. They're going to get substantially less than they would have under the Affordable Care Act. So, I mean, we can say we want to do what's best for the country, but rich people think what's best for the country is that bottom line.
That's right. It's what's best for them. But insurance companies are not making money hand over fist with the Affordable Care Act. It's more manageable. So, I think this is just geared towards making big business more beneficial than it is the actual consumer. So,
well, it's trying to take government out of healthcare, completely out. And, for people that have low incomes, we've subsidized healthcare and, under the Affordable Care Act, increased the amount we subsidized. And, as a health economist, I'm going to say this some people consider this kind of cold language, but it's not cold, it's what economists say. It is an investment in human capital. That's what we call people. We call them human capital. Because health, education, all those things, it makes our workforce more productive. So from an economist's viewpoint, this is a good investment. But I guess for some people's viewpoint, they'd rather not have government be in that business.
So Dr. Kramer, why has Canada been so successful with universal health care as opposed to what we're facing right now?
And that's one of the questions that we're trying to answer as health economists when we look and say, okay, Canada's healthcare costs, in fact, that was on that. Let me go back to the beginning here. You can see there's Canada. Their life expectancy is higher than ours, 81.4. And their per capita health spending, it's not quite half, but it's almost half. And that's one of the things that troubles us. I mean, Canada is a comparable, it's not, they've got a comparable environment, obviously. Some of it might be lifestyle. I just read an article a couple of days ago that said that this life expectancy, which we had at, there we go, was estimated at 78.9 and then down to 78.8. And they looked at why would it even be going down, and actually these numbers aren't that exact. So some sources actually say 78.8 for the entire time, but it's cardiovascular disease, it's obesity, it's a big one is diabetes. So diabetes, I mean, that's partly lifestyle, I mean, we're in a mobile country, people, drive a lot. And we've only recently started realizing that it's, health benefits to be able, of course, I'm from Detroit, everybody drives. In fact, we had an economist come from, actually from Russia. She was studying here, and she was making fun of me because I drove next door. We have a building next door, and I drove. It's like half a block. I mean, it's not even half a block. It's I just drove to the next parking lot. She's like, nobody would do that in Europe. So, I mean, that's part of our culture that we kind of have to get over. Another thing is, I was talking with another health economist from Spain, and she said that they are totally ingrained culturally with preventive care. We're not yet in this country. I mean, they don't even think twice about preventive care. Whereas here, we've had to encourage people to use preventive care. Prenatal care we've gotten good on at the last few years, but there was a time when we were really bad at prenatal care. Vaccinations, things like that. Not everybody subscribes to in this country. So in Spain, they have lower health care, and it's national insurance. But it's more cost, lower cost, but they already just incorporate that. It's part of their mindset to use, I mean, that's at least what her viewpoint was. It's part of their mindset to use preventive care.
But wasn't that really the whole premise of the Affordable Care Act?
Right, yes.
Preventative care?
Yes. I mean, that was a big part of it, yes.
But it hasn't been in place long enough for
Correct.
it to be right, and for it to be culturally the norm.
Absolutely.
You have that word like cultural norms.
Right. It hasn't been long enough to.
Yeah, it hadn't been enacted long enough and in place long enough for it to be culturally
correct
intertwined with with the country. So
right.
I mean.
True. And it also hasn't been long enough to see the results of preventive care. I mean, if I have preventive care today, that doesn't mean my health care is going to be cheaper tomorrow. Right. It's, over your lifespan, your health care is going to be cheaper. Right. So we haven't had enough time to see those results yet either.
So how long has Canada had their national insurance in place?
Oh, you know what? I don't even know.
80s, maybe, Dr. Kramer?
As long as I've been studying it, though.
It's been over 20 years.
So at least 20 years or more.
Mm-hmm. Okay. Yeah.
Yeah.
Well,
Costa Rica as well, too.
Mm-hmm.
Costa Rica
but I use Canada because they're our neighbor.
Yeah.
So it's like, why can't we?
Now, the other thing is, I'm just looking here, Canada Healthcare Act of 1984.
So since 84? Okay.
Well, that was their last healthcare act. They may have even had it before then. But so the other thing, though, the other thing is, in a lot of countries where they do have preventive care and they have national health insurance, they also have what they call a fallback, and that's where, again, it does tend to favor the rich in that if you want above and beyond the basic care, you might have to pay out of pocket for it. So they have a minimum, they have a basic care, but if you want something above and beyond, you may have to pay more. So in other words, they may have care that has co-pays and deductibles. If you want no co-pays and no deductibles on your plan, you can buy a supplemental policy to fill in those gaps. But then you're buying that policy on your own. Kind of like we do with Medicare, actually. Medicare, there's a Medicare supplemental policy that fills in the co-pays and deductibles if you want. And, you've got basic Medicare coverage, but then you can buy a supplemental policy as well.
But if you have pre-existing, you may not be able to be covered by that, correct?
Not necessarily, no. A lot of times pre-existing conditions are covered. If they are a covered benefit, they're covered whether it's pre-existing or not.
Okay. It just
But
depends on what it is,
deductibles
right?
might be bigger or yeah.
Okay.
So I just did Louisiana for you guys. You can actually go on that map and look at particular states. You can look at particular counties. So here's Louisiana. Actually, if you're 27 and you make $100,000, it's neutral. So same break, whether you were under the Affordable Care Act or the, which that's all of us, right? 27 and making $100,000.
Right.
But again, you can see the higher incomes are the ones that end up getting a smaller tax break under the new proposal. Just give you a little bit of an idea. Again, this is the change from the Affordable Care Act to the ACHA, the new proposal. This was Orleans County, which I don't think, actually, you guys don't count them counties, right?
Parish.
What's that? I was like, what's up with this? But I don't really think this is where your school is it? But anyway, it sounded, looked close. So this is, anyway, one of the counties in Louisiana. And you can see, again, income levels that are lowest are the ones where you're going to actually get fewer tax breaks. This is the amount of your tax break. So less of a tax break with the proposal as compared to the Affordable Care Act. So if you're 27 and you make only $20,000, the average change is going to be a reduction of $1,370 in your tax break. Get an idea of the numbers.
Right.
Yeah. All right. Well, somebody had asked about the Veterans Administration. And actually, the VA benefits are, they don't change under either act. However, a lot of veterans choose to purchase supplemental coverage so that they can have a bigger choice of providers. Because, under the Veterans Administration, you go to the VA providers or the VA hospitals. So many of them chose to purchase marketplace insurance, in addition to the VA benefits. And for those who have that marketplace insurance, and if the Medicaid expansion is rolled back and they fall in that category, then they're back to VA benefits again. So there is a concern that this could put added pressure on the VA, the Veterans Administration, to provide coverage. And, some of the VA hospitals and providers would need to staff up, and they're actually, under a budget crunch, just like, a lot of people. So there's concern about that there may not be the budget to gear up for people coming back to the VA administration from the marketplace. No direct impact, but there could be that indirect impact. Sort of makes sense?
It does. I've heard from we've got quite a few veterans in school, and just in talking to them, I've heard that the services are very, very slow. Sometimes
Okay.
you don't get appointments, for months. So I can only imagine if the Medicaid piece of this is rolled back, and those veterans that have the marketplace then have to go to the VA, it's going to be a problem.
Yeah. Yeah. That's the concern, right? Right.
That's ridiculous.
So
All right.
Lorenzo here is a veteran, so we're asking him what's his take on the situation.
Well,
Oh, okay.
I didn't know about the VA benefits. I know, like, whenever I got out the military, they were telling me, maybe like 6 months, like, whenever I get out the military, 6 months, up to 6 months, I'll be covered under the VA. But
Okay.
after that, they told me, like, whenever you're in the military, you listen to what they say. And so, like, but they can support me. So that's why, like, I never, really went to the VA, because after 6 months, you're just cut out. That's what I was told when I was in
Okay.
the military. And then I had and so, like, whenever I got out the military, I tried to apply for Obamacare, but they denied me because apparently I didn't work at that time. So I just got out. So I had to go to the marketplace that I got Humana, and
So you did go to the marketplace and got insurance?
yeah, I got a Humana.
Okay, Humana, yeah.
But I was wondering, with the repeal of Obamacare, and then the Trump's healthcare plan, like, is it, because with each new administration, like, they're going to take it, it might be drastic if, after 4 years, there's going to be a new administration, and
Yeah.
would it be beneficial for somebody to buy into the government healthcare, or should they just go to a third-party healthcare insurer? Because it's going to keep on switching over and over, with each new administration. So, so without having to cause them more headaches later in the future, something more consistent that they don't have to worry about. What is your take? Should you
that's a choice that you have to make. I mean, I would still go by what coverage is best for you. I mean, with the subsidy, if you fall into a category where the subsidies still make the, government insurance the best option for you, I would still go with it. The one thing that's good is that the continuous coverage does count as long as you're insured under anybody. So even if you switch insurers, as long as you're insured by somebody for the entire time, that's not considered a lapse in coverage. So you can't really hurt you that way. You're not going to all of a sudden get a pre-existing condition clause. I mean, it's a hassle to be switching, but depending on how great of a tax break you get, it still might be worth it to put up with the hassle. I mean, that 30% surcharge that I said they were going to put on lapsed coverage, it's not considered lapsed, even if you go to another insurance carrier. So as long as you have insurance with somebody.
Thank you.
So it depends on your situation, I would think. So just to give you an idea which states we're talking about here, the colorful ones are those states that accepted the Medicaid expansion. States did have the right to opt out and do their own thing. So originally it was mandated for all states, and then there was a Supreme Court ruling that allowed states to set up their own exchanges if they wanted to. So these are the states that have the federal government's Medicaid or Medicare markets or medical markets. So this is Medicaid before the Affordable Care Act. You could qualify for coverage if you were a child, if you were pregnant, if you were the parent of a dependent child, if you had a disability, if you were over age 65 and below a certain income level. So these are all, means tested, meaning below a certain income level, and in those categories. Children had to be covered at least 100%. Most states covered considerably more than that. So children have never really been a problem getting coverage. They've been pretty well covered even before the Affordable Care Act. Many states decided to cover, even like I said before, as high as 300% the federal poverty level. However, the median for working parents before the Affordable Care Act was 61% of the federal poverty level. Now what that means is that somebody who made 62% of the federal poverty level would not qualify for Medicaid. And that's not a lot of money. That's pretty low income. So those are people that a lot of times ended up uninsured because they simply couldn't afford coverage and didn't qualify for Medicaid. So after the Affordable Care Act, non-elderly adults had to be covered up to, if they had incomes, up to 138% of the federal poverty level. So this is a big part of that Medicaid expansion. It added all of these people who were now eligible for Medicaid who were not before. So it's federally funded. It's federal government reimbursed states 100% at first. They're supposedly planning to decline that as states become, self-sufficient. Some other, administrative requirements for Medicaid. And the minimum benefit package was a big one also. So all states had to cover a minimum benefit. So again, this was standardizing some minimum requirements across states. Here's Medicaid spending. So this just goes to show you how much the federal government started contributing. So the orange is the federal government. So you can see the blue, that's state and local government funding. And of course, it's gone up a little over time, but the orange has gone up substantially. You can see $554 billion total, that's state and federal together, in 2015. So you can see that's the federal government helping states with that Medicaid expansion in those last couple of years, last 2 years, 2014 and 2015. Here's Medicaid enrollment. You can see it's gone up, especially in the last 2 years. You can see that real big increase at the very end there. That's the Affordable Care Act. And Medicaid, okay, so that's Medicaid. That's the Medicaid expansion. Somebody also asked about Medicare. Medicare wasn't part of the marketplace. However, the Affordable Care Act did increase fraud detection for Medicaid, put money toward that, funded some improved benefits for people who were on Medicare, and it closed that donut hole. Do you guys aware of the donut hole?
No.
For Part D? So Part D was really weird. Part D is the prescription drugs for Medicare. And what happened was it came in 2 different parts. So it came in, first of all, as coverage for prescription drugs, which it covered up to a certain amount. And then after that, there was a cap on how much it covered. And then there was catastrophic coverage after you paid a bit for yourself. So actually, the way it ended up happening was you would end up paying the first, let me get the exact figures so I can tell you. Okay, so you had a $250 deductible, first of all, that you paid out of pocket. Then you paid 25%. After you met your deductible, you paid 25% of the next $2,000, and the federal government paid the other $75. However, at that point, you maxed out. So anything after that, you had to pay out of pocket. So anything after that $2,850, that's the 25% of $2,000 plus your deductible, anything after that, you had to pay out of pocket until you hit $5,100, and then catastrophic coverage kicked in. So if your prescription drugs fell between $2,850 and $5,100 in the year, that money in between there, the $2,850 and the $5,100, you had to pay out of pocket. So the affordable, it was really a weird thing. So people had weird incentives, to try and stay below the cap, and then, try to get above the cap. So, once you're above the cap, try to get all your prescription drugs for like the next year. So it was just weird incentives because of the way it was set up. Anyway, the Affordable Care Act was gradually phasing that center part, that donut hole, out by 2020. And actually, the new proposal does the same thing. It keeps that in place. So a lot of those Medicare improvements actually were kept in place. The part that the new plan does not do is have surtaxes on real high income earners, which the Affordable Care Act did in order to help fund some of these things. So the American Health Care Act proposal does retain a lot of the benefits for Medicare, but it eliminates that surtax for high incomes. So that was part of the funding. Again, eliminating the tax on the wealthiest, kind of consistent with what we've been seeing. All right, so let's just take a look maybe at these exchanges. We've been talking about the healthcare exchanges. So if you don't qualify for Medicare, you don't qualify for Medicaid, but you fall, you've got low income, you will get some tax breaks when you purchase insurance. And you purchase insurance on these health insurance exchanges. So this is a great economic theory, a great economic, experiment. The idea being that competition would end up putting downward pressure on prices. So the federal government invited insurance companies to offer insurance policies to people who in the past hadn't been able to afford them. They now could afford them because of the tax breaks. So the idea also is that now you're going to have a whole lot of people large pool, which means you can spread the risk better. There actually was a tax credit up to 400% of the federal poverty level. People who made, of course, you got a bigger tax break the lower your income, but you got some kind of a tax break up to incomes of 400% of the federal poverty level. So, you know, the success is that, of course, there were fewer uninsured people. Some geographic areas have several options for people to pick from. Some of the problems, though, was that in some areas, insurers lost money. And so they raised rates or they ended up leaving the marketplace. Here's the federal poverty level, by the way. I've been talking about, you know, 138% of the federal poverty level, 400% now. So that just gives you an idea of what the federal poverty level is. So for a family of 5, the federal poverty level is $35,560. 138% of that you see is about $49,000. 400% is about $142,000. So that means you qualify for Medicaid up until $49,000. You qualify for some sort of a tax break up to $142,000. If $142,000 in income, if you're in a household with a family of 5. So I don't know if those numbers bring it home a little bit more.
Go to the family from 1 to 4.
Yeah.
And that gets real interesting. Because I just looked at that.
Yeah, I did too. I just pulled it up.
You just pulled it up?
Yeah. And that's across the board as far as for everything that's for federally funded program.
100% of the federal poverty level is $11,770.
Oh my God.
Yes. Medicaid eligibility threshold 138 FPL, 16,243.
Yep.
Okay.
Yeah.
And this affects
So that's for one person.
One person.
this
Yeah.
that chart, they use that across the board for like where I used to work for Head Start. They use this table to calculate if you qualify for services.
So I have to make 16,000 or less
to qualify.
to qualify.
For anything
For
relative
Medicaid. That's to qualify for Medicaid.
to funded program.
And then 400% would be what? 11,000 times 4? 44?
How does one live off of that?
Let me tell you, it's hard.
It is hard. Yeah. So 44% gets you some kind of a tax break in order to purchase your insurance.
Wow.
So in those insurance exchanges, again, the success is that we have some more people insured. The policies are more comprehensive. And we have seen health rates go up, healthcare, you know, we've seen increases in rates. But even with those increases, the Brookings Institute actually did a study, and they said that those increases would have been even worse without the Affordable Care Act. Now, that's one study. It was actually in Health Affairs, which is, this is an opinion, but Health Affairs is a respected health economics journal. Now, there are two, actually there probably are more, these are the two I happened to stumble upon, 2 insurance companies that actually have been making money. Molina, I like to focus on because they've been successful in offering their insurance through the exchanges. And so they're not one of the insurance companies that's raising rates or pulling out. They've been very successful. And one of the reasons is that they originally were setting up provider networks for Medicaid. So they were used to having provider networks in areas where people had incomes that were borderline Medicaid. So as people qualify for Medicaid and then maybe make more money and don't qualify for Medicaid anymore and get private insurance if they get, or I'm sorry, marketplace insurance, if they get it with Molina, it's an easy move for them. It's the same provider network. So, I mean, provider networks are sort of looking like part of the key toward making these exchanges you know, successful. The insurance companies that have left the market, a lot of times they're insuring people, their provider networks were established because they were insuring employer groups. So it's a different group of people than are going to be on, health insurance exchanges. So the provider networks seem to make a difference. Here's just, isn't this pretty? This is just uninsured rate among non-elderly in graphic form, and actually going back all the way to 1995. So again, you see that huge drop in the uninsured rate at the very end, again, because of the Affordable Care Act.
I can't see why it's not a no-brainer.
So here's the insurance companies that have done poorly and announced that they're going to be leaving the insurance exchanges in some states, Aetna, United Health Group, and Humana. And so that's the problem. I mean, the problem with exchanges, somebody asked, why are we looking at a new American Health Care Act? Well, because there are insurers who are leaving the marketplace and saying that they just can't make a go of it. It's not profitable. Some of them are making a go of it, but some of them are leaving. So that's, one of the concerns is that it's become expensive. They've had to raise rates or they've had to leave the market.
I think the changes that the American Health Care Act will enact will make those companies see more profits, and I think that's why
Yes.
it's the bottom line for them. It's not anything else. It's like what you said about, what did you call us? Health.
Human capital.
Human capital.
Human capital, yeah.
It's really not about how healthy you can be kept
Right.
or maintained, but it's about the bottom line for them. And with these individuals who are in economics, they're going to quickly learn that it's not personal, it's business.
Right, absolutely.
There is a lot, it's hard for me. I have to force myself to think the other side because, I tend to be more of a believer in government involvement in redistributing income. But the other side of it is that when government steps in, you do take away some of the incentives to be efficient. So if insurance companies, so I just have to give, the other side of the story, which is that those who want the insurance companies to be making a profit, thinking is that if they're allowed to be making that profit, it encourages them to be more efficient, and then it'll drive down healthcare costs overall, because there's an incentive for them to be efficient in order to make a higher profit. So that's the other side of the argument. And I can tell by your reaction that that's not one that you all buy into.
No.
But that's the other side of it. I mean, that's the theory is that you're going to have incentives to be more efficient. So, economists have been looking over the last couple of years at why are these insurance companies having problems. And one of them is that the rates, were set very low. So the insurance companies may have been optimistic about how healthy their pools would be. See, the problem too is that when you first start insuring people who haven't had insurance for a while, there's kind of a backlog. So maybe they've been putting off getting preventive care, or maybe they've been putting off getting, some care that they've been putting it off because they didn't have insurance. All of a sudden they have insurance, they're going to start getting that care. So for that reason, the healthcare costs could be higher at first, but down the road, preventive care, in theory, would make those rates lower. Well, if insurance companies didn't correctly anticipate that original sort of backlog, they could have priced their policies too low. And they also, in some cases, have pool sizes, pooled risk that's smaller than what they expected. There's also a couple of other things that were built in. There's this reinsurance. There's these three things: the reinsurance, the risk adjustment, and the risk corridors were things that were put in place to keep insurance companies from being having one insurance company that was disadvantaged compared to the others and therefore going out of business. So if you happen to have, for example, with the risk adjustment, if you happen to attract a sicker pool of people than all the other insurers, there was this risk adjustment sort of provision that would collect money from those who had good risk business and pay it to those who were insuring the sickest people. So this would prevent them from having an insurance company that ended up with a really bad pool that then ended up going out of business, and now you've got really sick people who don't have insurance. Same with the risk corridors. The risk adjustment was based on the risk of the people they insured. The risk corridors had to do with the profit. So if some insurance companies had real low profit compared to everyone else, there was a provision that you would redistribute money from those who were losing money to those that were, or from those who were making a profit to those that were losing money. So these things were intended to, for a couple of the risk corridors and the reinsurance was a 3-year transitional period, so that as insurance companies got used to their pools and were able to rate them appropriately, this would help them from going out of business immediately. One of the criticisms of this is that risk corridor, as part of the budget process, was made budget neutral. That was a requirement. Health and Human Services administers this. They're the ones that collect the money and repay it. It had to be budget neutral, which meant that if one particular year they had a lot of low profit companies losing money, Health and Human Services could not finance that by going into debt. They couldn't do that and then collect the money a later year. It had to be budget neutral. And that wasn't originally the plan when it was designed. So that requirement, which was part of the budget process of the federal government, has been criticized as one possible contributor to the insurance exchange problems. So here's Louisiana. I just had to do Louisiana for you guys. So these are the carriers that there were in 2017 and the rate increases that they filed. So this is the reason that the Affordable Care Act is criticized, because of these rate increases. So Blue Cross Blue Shield had 41%, HMO Louisiana 20, I don't know, somewhere around 25%, depending on what plan you had, because some plans have more benefits than others. Humana had about a 30% increase, Vantage about 31%, and Humana is going to be leaving the individual market at the end of 2017 because they're one of the ones that said they're leaving. They're not making money on it. So people who are insured with Humana, that was, I think somebody said they were with a Humana right now, so they're going to have to find another carrier at the end of 2017, one of these other three probably, depending on what happens with the American Health Care Act. So these are the kinds of insurance companies that are in those exchanges. And again, the idea being that hopefully they would be competing with each other, and that would help to keep healthcare costs down. Just giving you an idea of prices here. So this is in zip code. Is this a zip code for your school, I think? I think that's what I looked up.
Yeah.
So this is in that zip code, just to give you an idea of the kinds of plans that are there and what the premiums would be. So the highest, the platinum ones are the ones that have fewer copays and deductibles. So depending what kind of plan you want, it's about the prices that you'll see.
Who can afford that? Honestly, nobody.
Dr. Kramer, could you?
Well, but this is before the tax break, remember. So you pay for this and then you get a tax break on your
But you have
federal.
to pay for it to get the tax break.
That's correct.
This is what they.
In some cases, though, you can ask the insurance company will estimate for you what your tax break would be, and they'll reduce your premium for you.
Right.
Okay.
Right. You get the tax credit and the subsidy.
So you get the tax credit up front.
Okay.
Right. Dr. Kramer, could you kind of touch on the self-employed and like the independent contractors that fall above like the 138%? Because I've spoken to someone who experienced trying to attempt to go into the marketplace and purchase health insurance, and it was just extremely, it's looking like the prices that are listed here, and they went independently on their own and got a better rate.
Which is great, then they need to do that. And that's, I mean, if you're above the 138%, you won't get the tax break. In that case, you can go in this marketplace and see if these premiums are going to be comparable, but they might not be without the tax break. Mm-hmm. So you might be able to do better on your own looking for individual coverage or looking for an association or something that's pooling the risk. Because when you go on your own, you're being rated in the individual insurance pool. You might sometimes be able to find a pool of business that's got a better rate. I'm just trying to think of an example. I know, well, when I worked for Blue Cross and Blue Shield of Michigan, we actually had a group of bartenders. All the bartenders in the area had a bartender association, and they bought insurance as a group, just as if they were an employer, even though they were all independent, self-employed people, and they got group rates. So they were healthy.
Yeah, makes sense.
So you can do that. You can look for an association too.
Right.
And if you don't find an association, a lot of times those individual coverages are expensive. Somebody had asked about I know somebody sent in a question about the Cadillac plan. The Cadillac plan. This hasn't been implemented yet, but it was intended to help finance the Affordable Care Act, and it's a 40% tax on an amount that's above some threshold. So they decide what the benefit, a really rich benefit plan would be. And again, that's usually one that doesn't have copays, doesn't have deductibles. And this is actually an interesting concept because it penalizes people who don't have deductibles or copays. And from an economist's point of view now, this is part of your econ class, deductibles and copays are an incentive for people to look at what it is they're purchasing. You know that anytime the price of something is free, people are going to tend to overuse it. So deductibles and copays, if they're modest in amount, people can afford them, they actually are a good thing from an economist's point of view because they give you an incentive to at least make a decision about this particular product that you're buying. You don't just buy it for the heck of it because it's free. So you may, for example, decide that if you, I don't know, if you have a cold, you may wait 2 days to make sure it does, see if it goes away by itself. But if you've got free coverage, you may immediately go to the doctor. That's overuse of coverage. So deductibles and copays are one way to help control health insurance costs because they encourage people to not overuse the services or not, for example, don't go in and get tests just because the tests are free. You know, determine whether or not you need the medical tests first. You even have providers who, you know, they may, you know, order extra tests, you know, as a precaution, even though you may not need them. Instead of ordering one test at a time to rule out a particular disease, they may order all of them because they know you have an insurance policy that covers all copays and deductibles, so why the heck not? That increases the cost of healthcare. So copays and deductibles are an incentive to control that. So this Cadillac plan tax is a tax above a certain threshold for really rich plans that usually don't have copays or deductibles. So that's an interesting idea, but it hasn't gone into effect yet. As part of the budget compromise, this was negotiated to be postponed. It may be postponed forever for all we know. Labor unions are really against it because a lot of labor unions have negotiated in really wealthy benefit packages and they don't want to be penalized for that. There's a concern, of course, again, that there may be regional price differences. And so this threshold is an absolute threshold nationally, you know, doesn't take account of some areas that just have higher costs, for example. And then, of course, nobody really likes any kind of a tax. Everybody wants lower tax. Everybody wants to have the freedom to pick however they want to pick, even if it's a really rich plan. So that's that Cadillac tax. I don't know, is anybody familiar with that? Again, it hasn't gone into effect, so we don't have a lot of information yet.
Never heard of that. That was my name. It was you. We will.
Okay, here's the Selling Across State Lines proposal. Again, that's something that's included in the new proposal right now. That may go away. There are a lot of reasons against it. The biggest one being, it's actually not against the law for insurance companies to do that now. I mean, an insurance company can apply to a state. You know, if the state allows them to sell in that state, they're allowed to do it. Now, some states don't. A couple of states have allowed it, though, and insurance companies have chosen not to because it was too hard, mainly because it was too hard to negotiate the provider networks. So, an insurance company that's regulated in the state of Louisiana has a network of providers that they work with in Louisiana. So for them to go and sell insurance in Michigan, they have to come up here and negotiate with a whole bunch of providers in Michigan. And, the plan may be a really great competitive plan in Louisiana, but when it's placed in Michigan with a whole different set of providers, different set of demographics, different set of, health experience, it's not going to be the same plan anyway. So it's not like a really great plan in Louisiana is going to do real well necessarily in another state. So even if they sell across state lines, it's not going to be the identical plan. It's not like I in Michigan can buy the identical plan in Louisiana. What it is I could buy from an insurance company that's licensed in Michigan, but chances are they're going to make the policy adapted for Michigan. I mean, they have to, at least because of the provider network. It's going to be different. So, there are some concerns about that, and especially since some states have invited insurance companies to come from all over, and they have not accepted that invitation because it was just too hard for them to negotiate the provider networks. The other concerns, I put some things in quotes there, this race to the bottom idea is that what could happen, and not for sure, but it could happen, that now insurance companies start shopping around for the state with the least regulations, which makes the insurance companies then competing for who can provide the, I guess, worst contract because it's not regulated. So that's a concern too. And then this other thing that I put in quotes, this cherry picking, means that insurance companies could go into states only where they think there are healthy people in order to improve their risk pool. And that could end up leaving people who are in states with less healthy people with higher rated policies. It could end up hurting those people. So those are some concerns about selling across state lines. So the people who are proposing it, of course, are saying, well, there's going to be a lot of competition. If you allow all the insurance companies to come in and sell, say in Louisiana, there's way more competition than that can keep prices down. And that might be, I mean, that's a valid argument. We don't really know until it goes into play, though, whether or not that's really going to be the case or whether the provider problem is going to be too problematic for them. Any comments on that?
I have a question.
Yes.
Okay, my daughter has Kaiser under her dad's plan, but
Okay.
she's covered in Kaiser, which is covered in Louisiana, but it's up to the provider. Would that change as well under this new?
That's a private HMO, right? Not through the exchange?
I think it could be private. I don't know. He lives in California, and it was like under a child support order. So.
Right. So yeah, Kaiser, it's Kaiser Permanente, I think, is in California.
Yeah.
So if she's in Louisiana, the providers, are they considered out of network, or they allow that because she's physically too far away from California?
I don't know.
Okay.
I have no clue. But
because I think that's a provider network, and I think that
under Medicaid and United Health, and United Health won't cover her because Kaiser is a primary.
Oh yeah, okay, right.
So under this new act, will it help? Will the PPOs or whatever they're called, the PPOs and the HMOs, would they have to cover her at that point? Will Kaiser have to pay it in the state of Louisiana? Will they have to take it under the new act?
I still think it's up to I'm not 100% sure, but I would think it would still be up to the insurance company.
Okay.
But they still.
Up to the provider or up to the insurance company?
Up to I see what you're saying with the provider. The insurance company establishes what they're going to pay the provider. So Kaiser is really based in California. They have a whole network of providers in California. Typically, if you go outside that provider network, you're paying, out of plan rates to the provider. So you may have higher deductibles and copays.
Right, but they won't even cover her here in the state of Louisiana because they don't have any Kaiser doctors. That's why I was asking, is the selling across state line, would they at that point have to provide coverage in the state of Louisiana through every?
My understanding is that selling across state lines allows them to. It doesn't require them to.
Okay.
Anybody else have any other questions? Any other questions for Dr. Kramer?
I do have a reference page at the very end too, so I'll send these PowerPoints to you so you can get some of those references. And you can play with the maps if you want.
Oh, definitely. I want to go in and look at those with the tax credits. Those are very interesting. Well, Dr. Kramer, thank you so much. This has been a wealth of information.
Yes,
I have a better understanding of what's going on, because quite honestly, you hear all this stuff about the Affordable Care Act and the repeal and the replacement, and I really didn't understand it. So this truly helped me to understand what's going on.
Absolutely.
Keeping abreast of the change.
Well, I hope you got something out of it that you didn't already know.
Yes.
Yes,
Yes.
definitely. Thank you very much, and I'll be in touch soon. Thank you,
Okay,
Dr.
you're very
Kramer.
welcome. My
Appreciate
pleasure.
it.
Thank you.
Thank you. Bye-bye.
So